हेलो, नमस्ते सर।
हो गया वो तो कदों भी
नमस्ते
करना।
सर, एसपी यादव सर। गुड इवनिंग सर।
गुड इवनिंग भैया। तुम्हारे बात तो पता नहीं ये चल पाएगा कि नहीं भैया, तुम यो सूत्रधार हो तुम तो।
नहीं नहीं सर, बस सर आप लोगों की ब्लेसिंग्स है और साथ में रंगा सर है तो चल रहा है इसलिए।
ये तो है ही, असली तो यही है। मैं तो भैया ऐसे
आप
यू कैन फोर्स मी टू कम, इतने और है।
सर
बिल्कुल
सर ने इतने लोगों को क्या नाम ईएनटी का डॉक्टर बनाया तो
बनाया है।
आगे
हाँ, आगे भी और बनाए।
हाँ, अभी देखो आजकल के रेजिडेंट है ना, पढ़ने की कम आदत है। सर को देख के ना फिर और मतलब ज्यादा मोटिवेट होते हैं सारे
बिल्कुल
स्टूडेंट। हाँ
बिल्कुल
हाँ,
सर।
इवन हम भी होते हैं, हम भी एक बार किताब उठा के लग जाते
हाँ
हैं।
जी। आज मेरा कैमरा नहीं चलेगा सर। आज ये लैपटॉप का मैं कैमरा लाना भूल गया। हाँ।
ओहो,
कोई बात नहीं।
कोई बात नहीं, फोटो फिर भी दिखाई दे रही है।
हाँ जी, मैं सारे ग्रुप्स पे एक बार दोबारा डाल देता हूँ बच्चों का
हाँ हाँ, डाल दो डाल दो।
रिमाइंडर।
7 बजे शुरू करना है ना हमने।
हाँ जी सर।
हाँ चलो, है 10 मिनट अभी तो। रिमाइंडर डाल दो बेशक से।
गुड इवनिंग सर।
हाँ जी, गुड इवनिंग।
इवनिंग
पहुंच
डॉक्टर
गया सर
रवि।
टाइम पे।
गुड इवनिंग सर। मैं पहुंच गया टाइम पे आज।
ठीक है।
यू आर ऑलवेज इन टाइम
नम,
सर।
नमस्कार सर। गुड इवनिंग सर डॉक्टर यादव सर। गुड इवनिंग डॉक्टर उपेंद्र। गुड इवनिंग सर।
गुड इवनिंग सर।
गुड इवनिंग डॉक्टर रुबीना। वेलकम।
गुड इवनिंग डॉक्टर रमन, गुड इवनिंग डॉक्टर यादव सर, रंगा सर, डॉक्टर रवि सर।
गुड इवनिंग डॉक्टर रुबीना। गुड इवनिंग डॉक्टर रुबीना। आपने अपना पोस्ट ग्रेजुएशन कहाँ से किया है?
सर लेडी हार्डिंग।
हाँ, बिकॉज आई हैव सीन यू।
यस सर।
मैम
हाँ जी।
मैम शायद मैम सी से भी मैम ने यूजी करा है, राइट मैम? यू डिड
यस
योर
सर,
यूजी फ्रॉम मैम।
एमबीबीएस फ्रॉम एमसी सर।
अच्छा, विच बैच?
सर 2005।
अच्छा, 2005। वेरी नाइस, वेरी नाइस।
थैंक यू सर।
सर डॉक्टर उपेंद्र,
यस सर।
हमें भी लड्डू भिजवा दो सर।
सर आप यही तो आपकी देश का राज है सर, आप कम खाते हो सर। पढ़ाई ज्यादा हो, खाते कम हो सर। लड्डू कल कोरियर हो जाएंगे सर।
वेरी नाइस सर। थैंक यू।
जमाने के लड्डू खिलाऊंगा सर, एक दिन आपने आना है 7 अप्रैल को सर।
बिल्कुल बिल्कुल बिल्कुल। 7 अप्रैल को क्या है ओकेजन?
सर वी आर प्लानिंग कोबुलेशन टॉन्सिलेट में कोबुलेशन प्रोसीजर इन ईएनटी।
अच्छा अच्छा।
हाँ तो वो
वेरी नाइस सर, वेरी नाइस।
सुबह से शाम तक सब बच्चों को कोबुलेशन तो पढ़ाना पड़ता ही है सर।
नहीं नहीं नहीं, वेरी नाइस, बहुत ही बढ़िया।
हम प्लान कर रहे हैं सर, यूआई के बैनर के नीचे इसको करेंगे सर।
हाँ
हाँ, अभी तो
राइट।
पेन भी नहीं रखा है उस पे, इनविटेशन कार्ड पर पहले इनवाइट मैंने आपको कर दिया है सर।
थैंक यू सर, थैंक यू। बिल्कुल बिल्कुल।
आपका हम क्या नाम। और सर मेरा एक, आपके नाम है, एक बार हमारे एओआई हरियाणा के जो
Uh, Okay, sir, I think we can start now. So good evening, everyone. I welcome you all in this academic lecture series that we are conducting under the aegis of Haryana AOI. So I just wanted to share this incident with everyone that I got a call from the Dr. Rubina from Civil Hospital Panchkula as we were running our earlier lecture series of Haryana AOI. So the residents over there, they showed interest in presenting a case. So Dr. Rubina called me and she requested me that the resident wanted to participate and they also want to present one case. So I really appreciated the enthusiasm of the residents over there, and we have now planned this case presentation from the resident of Civil Panchkula. So Dr. Monica will be presenting the case of CSOM, and for today's session, our moderators will be Dr. Jesse Pasi sir. He will be joining us shortly. Then Dr. Ravi Meher sir. He is Director Professor and Head at Maulana Azad Medical College, Delhi. And we have Dr. Rubina Arora from Civil Hospital Panchkula. She'll be the internal examiner for today's case presentation. Ma'am is senior consultant at Civil Hospital Panchkula. So, Dr. Monica, I think you can start now. After
Yes, thank you, sir.
taking permission from the examiners.
Yes, sir. Good evening to all respected consultants. With your permission, I'm Dr. Monica, a third-year resident of Civil Hospital, Panchkula, Haryana. Would like to present my case on chronic sinusitis media. Shall I start, sir?
Yes, please.
Sir, my patient Saqib, 18-year male, lives in Paltana, Punjab, and is barber by occupation. He came to ENT OPD with chief complaint of right ear discharge since 6 years. In his history of presenting illness, the patient was apparently all right 6 years back. Then he had right ear discharge, which was insidious in onset, chronic in duration, progressive in nature. Initially, it was white in color, thin in consistency, scanty in amount, which is non-foul smelling, non-blood stain, no aggravating factor, no relieving factor, which then progressed to creamish yellow color discharge. It was thick in consistency, scanty in amount, foul smelling since 2 years, non-blood stain, no aggravating factor, and no relieving factor. In the negative history,
Okay,
there is...
so Dr. Monica,
Yes, sir.
we come to the characteristic of discharge in your case, right? So can you come to the first slide again?
Yes, sir.
Okay, so the discharge was initially white in color.
Yes,
and
sir.
Thin in consistency. So what type of discharge we are talking about here? White color and then thin consistency discharge.
Initially, it might be a mucoid discharge.
Okay, so how does a mucoid discharge look like? I mean, what are the characteristics of mucoid discharge?
So it is thin in consistency.
No, it is not thin in consistency. It is rather, it is thick
Sticky in
and
nature.
viscid.
Sticky in nature, sir.
It is sticky in nature, it is thick and viscid, and it forms a string sign, right? So
Yes, sir.
a mucoid, so probably when you say thin consistency discharge, to my mind, it is probably a CSF which is leaking from ear, a thin, translucent, transparent discharge coming out of the ear is probably CSF, not mucoid,
Sir,
right?
Ji sir. Sir, it can also be maybe discharged from the external ear.
So can you have discharge from the external ear?
Sir,
What are the structures which in the external ear which can cause discharge?
sir, in case of furunculosis.
Furunculosis, in case of furunculosis, when it bursts, it will be a purulent discharge, which might be blood stained. A small amount of purulent discharge will be there. A furuncle will have actually a purulent discharge, isn't it? It will not
Yes,
be
sir.
a mucoid discharge or a thin consistency discharge. So probably this history
Yes, sir. I
is
will
not.
correct it, sir.
So that is important. And then when you are suspecting a mucoid discharge initially, it will be a profuse discharge, not scanty,
Okay, sir.
isn't it?
Yes, sir.
So can you tell me why there's a profuse discharge in case of a mucosal type of chronic otitis media?
Sir, because of the presence of abundant amount of the goblet cells, sir.
Yes, yes. So the goblet cells which are there in the middle ear mucosa, and they actually cause a lot of discharge, profuse ear discharge, which
Yes,
is
sir.
coming, right? Okay. So initially, probably this patient, on the basis of history, what you suspect initially in this patient?
Sir, initially, CSOM, which is of mucosal type.
Yes. So that is what comes to my mind when you told the history of discharge. Later on, what happened there was change in change in the
Yes, sir.
characteristic of discharge. So again, like when you say creamish yellow color discharge, what comes to your mind?
Um, Basically, purulent discharge.
Purulent discharge, yes. But when you say creamish means you are having some fungal infection, candidiasis. In candidiasis, you will have creamish, curdy, white discharge. Creamy discharge, to my mind, comes from otomycosis or candidial infection in the external canal,
Okay,
right?
sir.
So probably I will not use the word creamish. You
Yes,
can
sir.
say that there is a greenish yellow color discharge, because greenish color can be seen in which condition, which type of infection?
Sir, Pseudomonas infection.
Pseudomonas, yes. So when you have Pseudomonas, there is a green pigment formation by the Pseudomonas bacteria. So there can be greenish colored discharge or yellow colored discharge. So yellow colored signifies that there is a purulent discharge,
Purulent discharge.
right? So
Yes, sir.
purulent discharge is there. It is thick in consistency, scanty in amount, foul smelling, non-blood stained. So now there is a change in characteristic of discharge. So now what is your interpretation? What problem patient is having?
Sir, now the patient is progressing towards the squamosal type of disease.
Okay, right. So can you have this change, like initially there was mucosal type of discharge, and then you have a scanty amount of discharge, and there's a change in, like initially you were suspecting mucosal type, and now you are having uh, squamosal type of disease.
Yes, sir. Since there is a change in smell of the discharge, as well as the quantity remains the scanty in amount.
My question is, can you have a change initially and now? Because initially the discharge was suggesting a mucosal type of chronic otitis media, and now after some time it has changed, and now the discharge is suggesting type of chronic otitis media. First of all, this question is it
Sir,
possible?
So actually the disease might have progressed, which has led to these changes in its course.
Okay, can you tell me what is the reason of a scanty discharge in case of squamosal type of COM?
Earlier, there is a less number of goblet cells. So there is a scanty amount of discharge.
No, that is not the reason actually. What is the etiology of squamosal type of chronic otitis media?
So because of the cholesteatoma formation and
So how does cholesteatoma form?
so it is because of the accumulation of the squamous epithelium.
So basic pathology is eustachian tube dysfunction, which leads
Yes,
to
sir.
negative middle ear pressure, and that leads to retraction pocket. So initially
Yes,
there is a small retraction pocket. Later on it enlarges and it has got a narrow neck. And in this pocket there is a collection of desquamated epithelial cell and forms a cholestoma. So this retraction pocket grows into the middle ear cleft and leading to formation of cholestoma sac. And this sac or retraction pocket is not at all communicating with the middle ear, right? The middle ear mucosa has goblet cells, but what is happening? It is a retraction pocket which is there, but it is not communicating with the middle ear space. And this retraction pocket will accumulate small amount of moisture and it will get infected and leads to discharging ear. But this discharge is very scanty because it is only in the sac which is basically discharging. It has no communication with the middle mucosa which contains the goblet cells, right? So probably that is the reason why you have just a very scanty discharge, and that is coming because of the infection which is occurring in the cholestoma sac, right? So that
yes,
is the
sir.
reason. And why do we have foul smell discharge? What is the cause for foul smell?
Sir, because of the putrefaction of the bones, or it might be because of the anaerobic infection.
It is not putrefaction of the bone. It is because of the putrefaction of the dead necrotic material, that is the desquamated epithelial cells which are there in the cholestoma sac, right? That is undergoing putrefaction, and there is and aerobic infection which is occurring in the sac, which leads to foul smell.
Yes,
Right?
sir. Yes, sir.
Sir, Dr. Yadav, sir,
Dr.
please give your inputs also. Sir, please unmute yours first, sir. Unmute. Sir, you have to unmute yourself first. Dr. Upender?
Dr. Ravi,
Yes.
Dr.
Hello.
Dr. Ravi,
Yes, sir.
Dr. Surendra.
Yes, sir. Yes, sir. Good evening,
How
sir. Sir,
are you?
please.
Good
I am
evening.
fine, sir. Please give your inputs also, sir. It is always better to have.
Actually, your question was initially the discharge was
Yes, sir.
profuse. Now it has become
Yes.
scanty.
Yes. So that
I
question still remains unanswered.
think
Yes, sir.
he has secondary cholesteatoma rather than the primary one. No? Hello?
Yes, sir. Yes, sir. We can
Hello?
hear you. Sir.
Dr. Ravi,
सर आपकी आवाज नहीं आ रही है सर. हेलो.
हेलो.
हाँ सर, अब आ रही है सर, बताइए.
हाँ डॉक्टर रवि, मैं ये कह रहा था कि इनिशियली डिस्चार्ज वाज प्रोफ्यूज.
Yes,
Okay.
sir.
And now it has turned to scanty.
Right, sir.
So that means the disease has progressed from mucosal to the squamosal, maybe a
Yes,
secondary
sir.
cholesteatoma.
Yes, sir. Yes, sir.
So that
Absolutely
should be
correct.
the cause in this case.
Right, sir.
Yeah.
So I was just expecting this answer from Dr. Monica.
Yeah, I understand. Yes, I understand.
So
Right.
Absolutely correct, sir. So you can actually have
Huh?
after mucosal disease also there can be conversion into secondary acquired cholestoma, right? So that is the thing. There is one primary acquired cholestoma and second is secondary acquired cholestoma. So there can be through the perforation also there can be ingrowth of the squamous epithelium inside the medullary cleft leading to secondary acquired cholestoma. Sir, Dr. Yadav, sir, your comment, sir.
Hello.
Yes, sir, we can hear you.
Yeah, I wanted to ask one or two questions from the candidate.
Yes, sir, please go on, sir.
Suppose there is a patient free of discharge, and then you see the ear and you don't find any perforation. So how will you explain that?
Dr. Monica?
Sir,
Did you hear my question?
yes, sir.
So try to answer.
Okay, sir, I think there are other residents also in the meeting. If
So
anybody can
anybody can
answer,
answer. That will be
yes, please.
much better rather.
Rather than directing all the
Sir,
questions to
if
Dr.
the
Monica, we can.
disease, if the patient had history since 4 to 5 days or more than 5 days, and then patient shows to OPD, then the initial ear infection might have resolved by itself. And so there is no discharge on otoscopy while patient actually had a ear infection.
I don't think this answer is all right. Anyone? In case of small children, it may be only wax.
Yes, sir.
Because initially wax is liquid or semi-liquid type, and this may be taken as a discharge more so by the educated mothers who are more concerned about their children.
Yes, sir. This has happened quite a lot.
So this is very important. Second, in case of adult, as in your case, sometimes what happens, there is a perforation in the attic and discharge is coming. This discharge gets dried up and there is a scab formation and discharge stops. And when you see, if you don't see carefully, you do not see. If there is a history of discharge in adult, try to see the attic and you will find a scab there. Remove that one and you will find the discharge and you will find the perforation also.
Yes, sir.
In some cases, there may be serous discharge, rarely. In which case you may or may not see a single case in your life, but there is a history of serous discharge. And that is also profuse, just like CSOM. Any resident?
Sir, viral laryngitis or eczematous cause in otitis externa?
That is very small amount of discharge. I am saying serous discharge and like CSF, it is plenty in amount.
Serous otitis media?
Serous otitis media, there is no discharge, I think. Any other resident? This is a very rare thing. You may or may not remember. Sometimes there may be discharge from the parotid.
Yes.
A fistula in the ESC. And in this case, when the patient eats something, the discharge increases. But that's a rare thing. But if you keep in mind, you can diagnose a rare case. And suppose that there is purulent discharge, no mucoid content. What is your diagnosis?
Sir, it is seen in malignant otitis externa, mastocytitis, as well as in eticoantral diseases, sir.
Not at all, not in anyone. This has been discussed before. That means only purulent, no mucoid content. That means middle ear is not involved.
The paranculosis.
You're very good. This is the answer. I told this has already been discussed by Dr. Ravi. So this is a good answer. Very good.
So, very nice, sir. I mean, I just want to tell you, sir, we actually had a young girl around 7-8 years old, and she presented with bilateral serous discharge from external aortic canal, and the tympanic membrane was absolutely normal, and she used to pour like anything from both the ears, and ultimately it turned out to be bilateral salivary fistula, which you told.
It's rare, but if you have in your mind, you can diagnose.
Yes, and then we operated both the ears, and we published this case in International Journal of Pediatric Otolaryngology.
This was worth publishing more so because it was bilateral.
Yes, it was bilateral. Yes, sir.
Even I have not seen in last from 45 years or so. So you are lucky.
And actually, sir, I could not believe the history of the patient. And the patient says, "मेरे कान से discharge आता है एकदम से." And I saw the ear; it was absolutely normal. So
that's why I asked this question, because
right. And so ultimately, sir, we had to admit the patient, and during admission, during the ward rounds, I saw that patient was actually discharging from the ear, and then we could convince ourselves, yes, it is actually coming from the parotid gland.
But if you can recollect, I said serous. I used
yes, sir, absolutely serous. It was, and we got salivary amylase done for this patient, and it was the discharge was, I mean, it was positive for salivary amylase.
I asked only question only to so that somebody will see such case rarely, and they will be happy to diagnose, and patient will be benefiting. In fact, otherwise this patient will go from one doctor to another. Some will do mastoid without any benefit.
Right.
Ask her. We can ask her to proceed. Or
yes, Dr. Muniga, you can proceed, please.
Yes, sir. Sir, in negative history, there is no history of cough, cold, fever, no history of ear pain, ear bleed, or hearing loss, no history of nausea, vomiting, vertigo, headache, tinnitus, diplopia, fever with neck stiffness. There is no history of nasal discharge, nasal obstruction, or recurrent cold. There is no history of throat pain, difficulty in swallowing, or difficulty in breathing. In his past history, there is no history suggestive of tuberculosis, hypertension, hypothyroidism, asthma, sexual disorder, or no history of previous hospitalization and blood transfusion. In his personal history, he
Dr.
has
Monica,
normal. Yes, sir.
Can you just stop? So this patient
Yes,
did not have any history of hearing loss?
No, sir.
Okay, so how can you explain that? I mean, why
Sir,
this
it
patient
might be because of the cholestoma. He might be a cholestoma hearer.
Okay.
For the simple answer may be he doesn't have much of a hearing loss, less than 30 decibels. So he is not aware of hearing loss.
Yes, sir. Dr. Pasi is here, sir. Good evening, sir.
Good evening,
yes,
sir.
yes. Very good evening. I am sorry for joining very late. I am just landed from my office.
Yes.
Okay. Please carry on.
Yes, sir. In his past history, there is no history suggestive of previous hospitalization or blood transfusion.
Okay.
Okay,
so I just wanted to know what all history will you ask to the patient to know whether the hearing loss is conductive type or sensory neural type?
Sir, we will ask patient that whether he is able to understand the spoken words.
Okay. So if he is able to understand spoken words, what type of hearing loss patient is having?
So then it is a type of conductive hearing loss.
Anything else you will ask? Okay, so you must ask whether the patient has better hearing in noisy environment or not.
Yes, sir.
What does that tell you? Suppose there is a patient with hearing loss and he says that I hear better in noisy surround. What is your inference?
You must have read otosclerosis. Same applies.
Yes. So what is paracusis villus?
Patient is able to hear in noisy environment, but has a hearing loss in the normal environment.
Okay, so why it is happening and what type of hearing loss patient is having?
Sir, patient is having non-conductive, conductive type of hearing loss. When we increase the amount of the volume, so the stimulus or the frequency that reaches to ear increases.
It is
he's
not the
able-
frequency, it is the intensity of the sound.
Intensity, sorry, sir. Intensity increases. So now he is able to hear what he was not earlier able to hear.
Right. So
Simpler answer is in noisy environment, people are speaking at a louder voice.
yes,
That's why the person is able to hear.
right. So in noisy environment, people raise their voice intensity, and this raise in intensity is able to overcome the conductive deafness which the patient is having. And so the patient hears better in noisy environment. But it is actually reverse in case of sensory neural hearing loss. So when patient is having sensory hearing loss, even if you raise the intensity of the sound, his hearing becomes poor. So in noisy environment, the patient will have poor hearing in cases of sensory neural hearing loss. So another way to know what type of hearing loss patient is having.
Yes, sir.
Okay.
Yes, sir.
So can we go ahead, Dr. Pasi sir and Dr. Yadav
Sure.
sir? Okay, so we come to the examination now.
Yes, sir.
Hello, Dr. Ravi. Dr. Ravi,
Yes, sir. Yes, sir.
I
Yes, sir.
just wanted to ask one question.
Yes, sir. Please, sir.
Generally, we all know that there is a gap of few months or few years between the appearance of the ear discharge and recognition of hearing loss. Why is it so? It takes a few months to years for patient to appreciate hearing loss.
Dr. Monica, can you please comment on sir question?
So I don't know the answer, sir.
It has been described,
Very simple. Dr. Yadav has already given you the answer in the previous this thing.
So he might have with the passage of time, he might have realized that he has started to responding or in a low volume. People has to scream or they have to speak to him in a high intensity so that he is able to hear.
No. It's not that. Suppose you start having conductive hearing loss because of whatever reason. At what level you will be able to appreciate that you are having a hearing loss? At 10 dB, you will be able to appreciate?
No, sir.
Hello?
No, sir. No, sir.
So, at what level you will be able to understand, you will be able to appreciate that you are not hearing properly?
So at 20 to 30, it is a mild hearing loss.
What is the definition of perceptible hearing loss? Hello, can you hear me?
So other residents who are present in the meeting can also answer. If anybody knows.
I'm asking the same question. I'm just prolonging it. Perceptible hearing loss means the level of hearing loss where patient can perceive that he or she has the hearing loss. And it happens generally around 30 dB onwards. So it takes a while for patient to develop that level of hearing loss in chronically discharging ears. That's why they don't, there is a gap of few months to few years between the appearance of the discharge and the perception of the hearing loss. Okay.
If I can elaborate, in normal person, in socially adequate hearing, normally we speak at 30 decibel. or 30
Yes, sir.
Till that they will not be able to appreciate that there is a hearing loss. Suppose it is less than say 30 decibel, 25, 20. Is it clear to you or no?
Yes, sir. Yes, sir.
Okay, Dr. Monica, you can continue with the examination part.
Yes, sir. Sir, on general physical examination, when I examined the patient in a well-lighted room, he was sitting comfortably on a couch and was well-oriented to time, place, and person. His build was normal, nutrition was normal. On his vital examination, his blood pressure was 126/84 mmHg in right upper limb in sitting position.
Any positive examination finding in general physical examination?
No, sir.
You can come to local examination.
Yes, sir. In local examination, first I'll be describing about the right ear. In right ear examination of preauricular region, on inspection, there was no swelling scar in sinus. On palpation, there was no tenderness, no local rise of temperature. In auricular region, it was normal in shape, size, and placement, and there was no tragal or mastoid tenderness. The retroauricular groove was not obliterated, and there was no scar. On examination of external auditory canal, there was a discharge which was on dry mopping, seen that it is creamish yellow in color, mucopurulent, scanty in amount, non-foul smelling, and non-blood stain. On examination,
just a minute. Let me go to the previous slide. Okay,
yes,
so when do we say that the pinna is normal in shape, size, and placement?
sir, the pinna is normal in size when we see the size of pinna from the supraorbital ridge till the ala of nose. We'll mark the horizontal line from these landmarks, and if the size is approximately to that size, then it is normal size.
Okay.
And in shape, it might be a microtia, anortia, or
When do we say that a pinna is normal in shape? So we say that pinna is normal in shape when you can identify all the parts
all
of
the
pinna.
anatomical, yes, sir.
Yes, all the parts of the pinna. When we say
Yes, sir.
normal in size, the size is 1/3 of the vertical part length of the face. Or you described that it is from the area of the nose and the superior orbital margin. So that is approximately 1/3 of the length of the face, right? Okay. And when do we say it is normal in sight or placement?
Sir, in placement, in
Pinna might
mastoiditis,
be low placed because pinna
yes, sir.
develops from where the pinna develops. It develops from the first and second branchial arches.
Second branchial arches.
So
Yes, sir.
it develops from inferior to superior. It travels from inferior to superior. So it might get arrested, and there might be a pinna which is low set pinna. So when do we say that the pinna site is normal? So we have to check for the Frankfurt's plane. You know something about Frankfurt's plane? So when the patient is in Frankfurt's plane, the line, you just draw a line posteriorly, and it should just cut above the superior part of the external auditory canal.
Yes, sir.
Right. So if the external auditory canal is lower set, lower down, then it is said that the pinna is low set, or it's not in normal position. So Frankfurt plane you should remember.
Yes, sir.
Okay, next.
What are the common causes of displaced pinna other than congenital?
Right.
Sir, displaced pinna can be seen in mastoiditis.
Yes.
Yes.
And
or it's very important.
Sir, in Down syndrome.
those are all congenital conditions.
Yes, sir.
Acquired causes of displaced pinna.
Sir, post-auricular abscess.
Yes.
Okay. What about post-perichondritis?
Yes, sir.
What about post-operative?
Sir, post-operatively,
It is a very common finding. Patient complains of displaced pinna post-operatively. And you must have noticed it happens post-operatively. If it happens, what is the cause?
post-operative.
Yes, routine surgery that you do post-operatively, if you do not take precautions, certain precautions, it might get actually displaced. Lot of displacement will be seen immediately post-operatively, but over a period of time, this displacement gets less and less, but it can stay. What is the basic cause?
Pinna might not be approximated appropriately.
Yes, that's right. But what precaution you should take to ensure that it is approximated properly at the time of closure of the wound?
So first we mark the incision and then we make the hatch marks before the making
Yes.
incision of the skin.
Cross-hatching that we do is very, very important. You must observe in all cases. And also the layer-wise suturing should be proper. Muscle, skin, and periosteal. Okay, then you
Yes,
are unlikely to have displaced pinna. All right, go ahead.
Yes, sir.
In this context, have you heard the term oral proptosis?
Oral proptosis, AURAL.
AURAL, not for
No, sir.
अभी डॉक्टर पास ही बताएंगे.
Oral proptosis.
Protrusion of the pinna.
Same thing. The oral proptosis can happen in post-oral abscess.
Yes.
And malignancy of the temporal bone.
No, there is only thing this abscess what you were telling, post-oral abscess.
Okay.
This is an old term, so people may not be aware. That's why I asked.
Yeah. She can continue, sir?
Yes, sir.
Okay. Now you tell us about the discharge once again and go slowly, one by one. Don't be in a hurry to speak every word.
Yes, sir.
About
Sir,
the type of discharge. Describe that.
sir, it was yellow in color, mucopurulent in nature, scanty in amount, non-foul smelling, and
What is this
blood
word
stain.
creamish? What is this word creamish? What do you want to say?
That's all. We have the creamish discharge.
Okay.
In other words,
Scanty yellowish.
Scanty and
in
purulent.
color. Purulent.
भाई
If
when you
it
say
is-
म्यूकोपुरुलेंट इसका मतलब कि म्यूकस आ गया है इसके अंदर. There is mucoid discharge. There is some component of mucus which is coming from the middle ear cleft, from the goblet cells. Right? तो
Yes, sir.
mucus discharge जो होगा, mucoid discharge काफी ज्यादा होगा. It will be profuse in amount. Okay.
Yes, sir.
So from the quality of the discharge, characteristics of the discharge that you explained, we cannot make out whether you are heading towards an aticoantral or your safe type of mucosal disease. We cannot deduce anything out of it. Hello.
Yes, sir.
Okay, let us see what you have to say next. Go ahead.
Yes, sir. Sir, in tympanic membrane examination.
If this discharge, when the discharge is more, It is because of goblet cells.
Yes,
Yes.
sir. Yes, sir.
But goblet cells are always there. So the discharge should be copious in every case. Why it is copious in some cases, especially in mucosal type?
Middle ear, we have less number of goblet cells. So when the disease pathology is of middle ear of origin, so then we have a scanty amount of discharge.
I'm not asking scanty. Why sometimes there is a copious discharge? The discharge is more. And that is invariably mucoid. Any other resident? Some of the mucosal cells are changed into goblet cells during the disease. There is a
Okay, sir.
You can proceed. Hello?
Hello. Yes, sir.
Proceed.
Yes, sir. Sir, in examination of right ear tympanic membrane, cone of light was distorted. On pars tensa, it was intact. There was grade 1 retraction. Lateral process lateral process of malleus was prominent, and annulus was prominent. The anterior malleolar
Have
fold.
you are you going to show us the diagram or
Yes, sir.
the
Yes, sir.
picture?
Yes.
You
Yes,
show
sir.
that and then explain.
Yes, sir.
Put your next slide and then explain the findings. Yes, now explain the findings.
Yes, sir. So there is the anterior malleolar fold is distorted. Posterior malleolar fold is intact. On examination of on examination of pars flaccida, there is deposition of white flakes, which on dry mopping was not removed, is suggestive of cholestoma flakes.
Okay. What do we see in the posterior inferior quadrant, that whitish patch? Can you appreciate some whitish patch in the posterior inferior quadrant of pars tensa?
The cursor is lying on the same thing. Please.
Is it this one?
Yes, this one.
Is it tympanosclerotic patch?
Yes, sir.
Okay, if you are talking about the attic region, pars flaccida, you explained it further, the grade of the perforation or retraction, whatever you want to say.
Past study, there is grade 1 retraction, and there was white flakes was present, white debris or discharge was present.
Do you find frank flaccidoma flakes in grade 1 retraction of pars flaccida? What happens in pars flaccida grade 1 retraction?
But there is dimpling of pars flaccida.
Dimpling.
Yes, sir.
So dimpling will bring out the cholestoma flakes.
No, sir. It seemed like there is a discharge or some collection of flakes was there. So on dry mopping, it was I was not able to remove those flakes.
Did you attempt suction clearance?
Yes,
Hello?
sir. Yes, sir.
So what did you find on suction clearance? Things would have been clearer. Your picture is not very good. It's blurred picture. We cannot appreciate much. So we will have to agree to whatever you are saying.
So the flakes were partially removed.
Okay, Dr. Monica, can you tell us the grade of pars flaccida retraction? Grading of pars flaccida retraction.
Yes, sir.
Yes,
in
what is
grade
grade 1,
one-
2, 3, 4?
Yes, sir. In grade 1, there is dimpling of the dimpling of the pars flaccida. In grade 2, the pars flaccida is retracted maximally and is draped over the neck of the malleus. In the grade 3, there is pars flaccida retraction, which is draped over neck of the malleus, plus there is erosion of the outer aortic wall. And in grade 4, there is deep retraction, which is there is accumulation of the keratin.
No. Grade 4 is, so grade 3 and grade 4 are divided by minor and major atic erosion. Okay.
Yes, sir.
So if there's a minor atic erosion, that is a sputum of the epitympanum is eroded, then it is grade 3, and there's a major erosion, then it's grade 4. So probably when you have some cholestoma flakes and the picture is not very clear, but probably it's a grade 3 retraction because there is a erosion of the sputum also. Then only you will have a cholestoma sac. No? In grade 1, it is dimpling. Grade 2, it's draped over neck of malleus.
Yes, sir.
Right? And grade 3 only there will be formation of a sac, and grade 4 में और बड़ा sac होगा, right? So probably it's a grade 3 retraction, though the picture is not very clear, but I think it's grade 3 retraction.
Yes,
Yes,
sir.
certainly it should be more than grade 1 and 2. The
Yes.
type of picture and cholestoma flakes you are sucking,
Right.
if it is correct. Okay, anything else you would like to tell in the middle year examination findings?
Dr. Ravi? Dr. Ravi,
Yes, sir. Yes, sir.
can we ask her, can we correlate the history which she was giving? Initially, there was profuse discharge.
Right,
then
right. So
found
can
out
you,
this
yes.
scanty. With this finding, it cannot be correlated.
Right, sir. Very, very, very valid point, sir. Dr. Monica, can you answer that question of Dr. Surendra's?
So the discharge was from the very nature, it was scanty in amount only.
Previously, you mentioned profuse discharge. You remember? We discussed it also.
Right.
Well, it was, I've mentioned scanty only, sir.
So
You
how
have
can you
written-
explain initially there was there was a history which was suggestive of mucosal disease, and later
Yes.
on
Yes, sir.
it
Yes,
turned out
sir.
to be squamosal disease. So
Yes.
how can you
Yes, sir.
explain this
With this
with
picture.
the finding you have presented in your examination?
The repeated episode might have led to the upstaging.
So probably one thing which comes to my mind is probably the patient had attack of acute subpurulent media followed by discharge, and probably it healed, and now because there was a eustachian tube dysfunction, now he has developed a retraction pocket. That is one possibility, if I mean, which comes to my mind. Sir, Dr. Surendra sir, can you?
I think that can be the reason. You are right. And the evidence of tympanosclerosis in the posterior part also points towards that only.
Right, sir.
Yes.
So, sir, can we go ahead, sir?
Yeah.
Yes, please.
Please go ahead with the rest of the examination. Can you just tell us the positive examination finding?
Yes, sir. Sir, in left ear.
No, right ear. You complete your right ear first.
Yes, sir. I've completed.
You are
with
still
right
left
ear.
with few things. Complete your right ear examination findings first. You haven't told us about hello.
Yes, sir. I've completed with the findings of the right ear, sir.
Okay, sir. Let us finish with the left ear now, and then we can go ahead.
Okay.
Please start with the left ear.
Yes,
Picture.
sir.
You can show the picture.
Yes, sir.
Fistula test, you will tell us later on.
Yes, sir. Yes, sir.
Okay.
Sir, in left ear, external canal was clear. Tympanic membrane was seen.
Only
Cone
the
of light.
positive finding. Tell us the positive findings only.
Yes, sir. So there was a grade 2 retraction in pars flaccida, and there was in pars tensa the annulus was prominent, and rest findings were within normal limits.
Is there any retraction in the pars tensa in left ear? Hello. Pars tensa is normal or it is grade 1 or grade 2 retraction?
So grade 1 pars tensa retraction is there.
So you didn't tell us earlier. If you have a grade 2 or 1 or 3 retraction in pars flaccida, should you have a normal pars tensa? There should be some finding there also. Okay, how do you say grade 2 retraction in pars flaccida?
According to pars, you asked about pars flaccida.
Okay, Dr. Monica, this is again a grade 3 retraction, at least minimum grade 3, not grade 2. In grade 2, you have the the membrane is actually draped over the neck of the malleus, isn't it?
Yes, sir. Yes, sir.
Here you can actually see the head of the malleus
Destruction.
also.
Yes,
And
it
this
is
is destruction
destroyed.
of the lateral attic wall. So it is at least minimum grade 3 retraction pocket.
What is
Pars
that
flaccida
white,
grade 3.
Dr. Ravi, what is that white structure anteriorly, anterior to the neck?
So probably that is probably some debris.
Debris and yes, anterior
Probably
malleolar
some debris
fold.
which needs to be cleaned.
Yes.
Okay.
Yes, sir. It's a wax debris.
Yes, yes.
Yes.
Okay, we can go ahead with the rest of the findings.
It cannot be wax.
This color wax.
Otherwise, the place is not for wax. Wax doesn't form near the tympanic membrane.
Right.
I think it is
It might be a cholesteatoma debris.
Yes.
Can be.
Epithelium.
Sir, it has a light brownish color appearance.
Yeah, there can be an accumulation of cholesteatoma flakes dried up and some element of desuccumulated epithelial cells dried up maybe lying there, and you can have this kind of picture. Okay, and any other positive finding in the left ear?
No, sir.
Okay, go ahead.
Sir, on tuning fork test,
Hmm.
on performing Rene's test with 256, 512 and 1024 hertz on bilateral ear, it was found to be negative, which is air conduction was more than the bone conduction. And Weber was lateralized towards the right. And on performing absolute bone conduction test, it was equal to examiner for both the ears.
Okay.
Sir, on examination of nystagmus, there was no spontaneous or evoked nystagmus. On facial nerve function examination, it was found to be normal on both sides. Fistula test was found to be negative on both sides.
What is your inference on tuning fork tests?
The patient has a normal hearing here.
So do you think it should be like this? Is it a correct finding? Normal hearing.
So,
Why there is lateralization of Weber on the right?
So can you tell us what is the degree of hearing loss this patient is having?
According to her, there is no hearing loss.
There is a hearing loss because Weber is getting lateralized.
Even this Rene is also negative.
So
And Rene is also negative.
It cannot be normally. Even
So-
1000 is negative.
Sir, it is negative with all the three tuning forks. So my question is, Dr. Monica,
Yes,
when
sir.
at what degree of hearing loss Weber becomes lateralized, and at what degree of hearing loss the Renes become negative? Normal, what is normal Renes? It is positive or negative? I think you got confused, right? So a positive Renes is normal. And when the Renes become negative, it is abnormal. So why the patient is having negative Renes in the left ear also when you suspect an intact ossicular chain? So probably you have wrongly written it to be negative. It should be a positive. Okay. Am I correct,
Yes, sir.
Dr. Monica?
Yes, sir. Yes, sir.
So you just tell me at what degree of hearing loss the Weber becomes lateralized.
Sir, when the hearing loss is 5 decibel or more, it becomes lateralized.
Right. Yes. So to 5 decibel, it is said that Weber is a sensitive test, and even a 5 decibel difference in the hearing of 2 ear can make the Weber lateralize. Okay.
Yeah.
Now the next question is, when does the Renes become negative? At what degree of hearing loss the Renes become negative? Anybody can answer.
The 30 decibel.
No, it is not 30. It's around 17 decibel. Okay. So if
Yes,
the
sir.
hearing loss is between 5 to 17 decibel, you might have a possibility that the Weber is lateralized, but the Renes is positive. Can you understand what I am saying?
Yes, sir. Yes, sir.
Right. So in this patient, because there is a small retraction pocket and a cholestoma, maybe there is an intact ossicular chain, right?
Yes,
The
sir.
pars tensis is normal. There is a retraction pocket in the pars flaccida. So probably there is an intact ossicular chain, and that is why the hearing is preserved in this patient.
Yes, sir.
Okay.
Yes, sir.
Sir, Dr. Pasi and Dr. Yadav, sir, your comments, sir.
Yes.
Yeah.
Yeah, it looks like that only.
And Weber get lateralized. You answered it, but answer it again.
Okay.
So when the hearing loss is 5 decibel or more, the Weber get lateralized.
You are not trying to learn anything. This is not related to hearing loss. Difference in hearing loss. Dr. Ravi has told, but you did not listen to him. The difference between the two ears is at least 5 decibel.
Yes.
Right, even 3 decibels.
Initially, sir, some books says 1 decibel. It is so sensitive that even 1 decibel hearing loss can be, difference can be appreciated by Weber.
That's why I asked again, she is not appreciating what you were saying.
Right, sir. So, Dr. Monica, you got the point which Dr. Yadav, sir,
Yes,
wanted
sir.
to.
Yes, sir. Now I've understood, sir.
And this may not be due to only conductive, it may be sensory neural also.
Yes.
The difference is more than 5 decibel. Understand?
Yes, sir.
Because both ear are having sensory neural deafness, and there is a difference of 5 decibel, it will be lateralized to the better ear. Yes, it will. So you can proceed.
You can proceed. Dr. Rubina, you can also pitch in if you have any questions, please.
Yes, sir. I will.
Sir, on examination notes, on external examination, anterior rhinoscopy.
You tell, otherwise you just leave.
Sir, it is all within normal limit, as well as throat and neck examination was all within normal limit. My provisional diagnosis is right ear active squamous.
Just hold on, Dr. Monica. I mean, there are two very important things. First is the facial nerve examination. Did you perform?
Yes, sir.
And fistula test, which Dr. Pasi wanted to know.
She has
Yes,
done
sir.
actually.
Okay. Facial nerve is normal and fistula test is negative. Okay. So we
Yes,
can
sir.
come to the diagnosis.
Yes, sir. Sir, my provisional diagnosis is right ear active squamosal chronic otitis media with mild conductive hearing loss, with no intracranial or no extracranial complication, with DNS to right.
Incomplete.
About DNS, Monica, do you want to attach some importance to this component of your diagnosis? Is it a symptomatic DNS or?
Sir, it is an asymptomatic DNS.
So then you don't have to write.
Okay, sir.
When we write DNS means for an ENT surgeon, when you write DNS, it means symptomatic.
Yes, sir.
And I
If
think
it is not,
you need to write no intracranial, extracranial complication in the diagnosis. Do you think it is necessary to write this? Can you hear? Hello?
Yes, sir. Yes, sir.
Why you have written no intra or extracranial complication?
So since the case is a
This is superfluous. There is no need to write. As
yes,
far
sir. Okay, sir.
Sir, what about the left ear, Dr. Ravi?
Left ear, yes.
Yeah, there are findings in left ear also.
yes, you have missed out completely left ear
Sir.
because it is not discharging. Huh?
No, sir, I have explained that in the tympanic membrane examination only. I have explained.
In the diagnosis also it will come, na?
diagnosis.
The left ear is not normal. So you need to put the findings of the left ear in the diagnosis also.
Sir, she can put left inactive squamous chronic
Yes,
otitis media for the
yes,
left ear.
Yes,
yes.
That's right. And there is no need to write this extracranial complication or intracranial complication.
Yes, sir.
So, Dr. Monica, can you tell me the recent classification of chronic otitis media which is used? Recent classification जो है हमारी, because now we don't use safe and unsafe terminology.
Yes, sir.
and we
It
don't-
is.
Yes. So what is the classification which is
Sir,
recently given in the Scott Brown?
Sir, it is. It is mucosal chronic otitis media or squamous chronic otitis media, which
Yes.
can be subdivided into as active or inactive
Yes.
types.
Right.
When
So-
will you say active?
So when there is a discharge on examination, or patient complains of discharge since more than
Yes, you are.
sir, if it's more than 6 months.
More
No,
than
not 6 months.
More than 2 weeks. Not 6 months. Okay.
Okay, sir.
So the classification is basically mucosal type and squamosal type, active and inactive both. And there is one more terminology which is used in the classification, which is called as healed otitis media. Right. So healed otitis media, meaning the perforation which had occurred is now healed, and there are some signs of healed otitis media, like maybe there is a dimeric tympanic membrane, or there is a tympanosclerotic patch, or there is some retraction of the pars tensa. So there is some finding which suggests that this is a healed otitis media. And if there is a cholestoma flakes present, the ear might not be discharging. But if there is a cholestoma sac and cholestoma flakes present, it is active squamosal disease. It is not considered as inactive. So in this patient, there might be absolutely dry, there's no discharge. But if there's a cholestoma sac and cholestoma flakes, then it is active squamosal disease. Okay, am I correct?
Yes, sir.
Okay, so there is another terminology which is used, which is called as eosinophilic chronic otitis media. what is eosinophilic chronic otitis media? So that is also given in the new Scott Brown 8th edition. It means that the patient is having some allergic component, allergic rhinitis and asthma. And because of allergic rhinitis and asthma, there is eosinophilic deposition in the middle ear mucosa also. So there's a lot of eosinophils in the middle ear mucosa, and it actually comes from the nasopharynx only. The infection and the allergic component comes from the nasopharynx, and the patient has thick purulent discharge also, and that is called as eosinophilic otitis media, and it responds to antihistaminic therapy and nasal sprays. So when you give antihistaminic sprays and antihistaminic tablets and nasal sprays, the discharge dries down and becomes all right, right? So that is eosinophilic chronic otitis media.
Dr. Ravi, is it the same you're talking, allergic otitis media?
Yes, I think that is allergic otitis media only, but the terminology which is now used is
Okay.
eosinophilic.
Okay.
So these are all new terminologies which are there in the Scott Brown, and I think the resident must be aware of these new terminologies.
Right, right.
So my question is why we have stopped using safe and unsafe terminologies now? Dr. Monica, can you answer? Why we are not using the safe and unsafe terminologies now?
If you don't know, you say no, so that no time is wasted.
But as complication can occur in both diseases, both type of diseases.
Don't say
Very
both.
nice.
Say,
Very nice. Very
say-
nice.
Don't use the word both. Use in mucosal.
Yes, sir. In mucosal as well as in squamosal type of.
Don't use the word both. It can be there in the mucosal type also.
So,
Dr. Ravi, I think there was a good article by G.G. Browning in long back in 80s. He
right,
said
sir.
unsafeness of safe here.
Yes,
There was a
that
very good
I
article.
still remember that article was how safe is
Is the safe here.
how safe is the safe
How
CSOM?
unsafe? How unsafe is the safe?
How unsafe is yes, sir, something like that, and it suggested that there is a 5% complication rate even in safe CSOM.
Yes.
So I remember. I mean, I don't remember the exact details of the article, but I have read this article.
And so one more query I wanted to ask. Should the candidate mention about the amount of hearing loss or the degree of hearing loss in the diagnosis? Like active squamosal chronic otitis media with mild to moderate.
I think the diagnosis with hearing loss must be mentioned because patient might be having a profound deafness or patient might be having mild to moderate. So probably it gives an idea about the management, further management required for the patient. So I think it's a good idea to tell the diagnosis with the degree of hearing loss and type of hearing loss.
Right, sir. So just sorry to interrupt, but we have 15-20 minutes more, and so we can discuss the management part now.
Yes, yes. So how will you manage this patient? Dr. Pasi is there, sir, or sir has? Okay, how will you manage this patient, Dr. Monica?
We'll have our routine blood investigations done. We'll have an X-ray of mastoid and examination under microscope of both the ears. We'll do a pure tone audiometry. We will do a pus culture sensitivity for the discharging ear, and we will also do a HRCT temporal bone.
Okay, so I have some reservation about the radiology. You said you will do X-ray mastoid also, and you will do a HRCT also. I mean, why to send the patient for 2 radiological investigations, right? So if you have the facility of HRCT, I think you should straight away go for the HRCT, not get a X-ray mastoid, because X-ray mastoid is going to give very little information, right?
Yes, sir. We prefer CT also.
Right. So you don't write X-ray mastoid. If you prefer CT, I mean, if your institution is writing CT scans for mastoid, just go by CT scan, not X-ray mastoid. Right.
Yes, sir.
Sir,
Yes.
so can we completely omit the saying X-ray because will it not
It
cause
depends.
any?
It depends on the in the institution where you're working. If there is no facility of HRCT, then even X-ray is desirable because it will give you some information. For example, it will tell you about the dural plate and the sinus plate and the degree of pneumatization, which will help you to plan the surgery. But if you have the CT scan facility available, then you can straight away write the CT scan. Don't get both the investigations. That is
Yes.
my point.
The candidate can say CT directly, right?
Right? Basically, whatever you are following in your institution, you can say that.
Thank you, sir.
Right? And sometimes there can be questions like, if you are not having the facility of the HRCT, then why are you getting? I mean, what are the information you are getting from X-ray mastoid? So that question must be answered. And if you have only X-ray mastoid and you want to send the patient for CT scan because CT scan is not readily available, then what are the indications in which you will actually get a CT scan done? So there can be certain indications where CT is mandatory, right? So Dr. Monica, can you
Yes, sir.
tell us the indication of CT scan, which is mandatory? You must have a CT scan before proceeding.
So when we suspect there is some complications of the
Yes,
whether it's intracranial or extracranial, any complication is there.
right.
And
Okay.
before, if we are planning for a mastoid exploration, then we should see, and in case of specifically in case of cholesteatoma, we can also do CT temporal bone to see the anatomy of the middle as well as the internal
No,
ear.
no, no, that is not. I am asking in which case it is mandatory to have a CT scan. So one
Sir,
is if you are suspecting complication,
yes,
intratemporal
sir.
or intracranial.
Yes,
What is the
sir.
other indication?
Sir, when patient is a case of revision mastoiditis.
Yes, revision mastodectomy. If you're planning a revision surgery, we don't know what has happened in the
Yes, sir.
previous surgery, right? So you want to get, okay, revision surgery. Any other indication? So another indication is when you have congenital deformity of the external canal or pinna.
Yes,
Because
sir.
in these patients, there can be abnormality of the middle ear also associated with facial nerve abnormality also, right? So if there is an external deformity of pinna, there is a microtia or there is a canal stenosis or there is some deformity of the pinna, then you must get a CT scan to know the middle ear anatomy also. Okay.
Yes, sir.
And also in cases where uh, there is a only hearing ear, you have to be extra cautious to operate this patient, right?
Yes, sir.
Okay, so after this,
Sir,
okay,
we
what are the
will,
CT findings in a case of cholesteatoma here? CT findings.
sir, I'm not able to understand the question.
Okay, what findings you expect in case there is a cholesteatoma of the middle cleft on CT?
Sir, there is erosion
Of what?
of attic.
Okay, erosion of the attic. So one of the important
So,
feature of a cholesteatoma on CT is erosion of the scutum, blunting of
yes,
the
sir.
scutum. So the initial, the most common site is Prusak space, right? So the lateral boundary of the Prusak space is basically the pars flaccida and
Parts
the
flaccid.
bony scutum. So if there's a cholesteatoma, there will be erosion or blunting of the scutum. That is one of the important finding in CT. Okay, what else?
Yes, sir. Sir, ossicular erosion
Yes, so there could be ossicular erosion. Very good. And
and there might be opacification of middle ear cleft.
yes, so there could be because you can't actually differentiate cholesteatoma from the soft tissue of the middle ear. So in the CT, you will see that there is a opacification, there is a erosion of the ossicles, there is a erosion of the scutum, and there can be erosion of the lateral semicircular canal and facial canal, the fallopian canal. So these findings can be there. And there, if there's extensive cholestoma, there can be erosion of the sinus plate and the dural
And
plate also.
dura plates. Yes.
Right? So
sir.
these are the findings you expect in a patient with cholestoma. Suppose you want to differentiate.
Ravi,
Yes, sir.
Dr.
Yes,
Ravi,
sir.
another indication for CT is pediatric cholestoma. It is said to be very extensive. So pediatric
Right.
cases, CT is indicated.
Right, sir. Absolutely correct. So how will you differentiate whether it is a soft tissue in the middle ear or it is a cholestoma? Can you do something? It's a more of
MRI.
an academic question. Yes, MRI. Which MRI? कौन सा MRI कराना है?
So T2 weighted.
Okay. Diffusion weighted MRI can actually differentiate cholestoma from the secretions and the mucosa. Okay.
Yes, sir.
So next, so you have got CT and you have got a P2 altimetry and the patient is PSA fit.
Yes, sir.
What next?
Sir, we will plan the patient for mastoid exploration under general anesthesia.
Okay. So what counseling will you do before surgery?
Sir, we'll explain the patient that there might be no change in hearing. There might be discharging ear even after surgery, and there might be deviation of mouth or facial nerve paralysis.
So hearing all the three things, patient will run away from you. He will not get the surgery done. You are straight away telling when you counsel the patient, you have to tell the first thing is what is the disease and what is the need for surgery. And complication comes in the end. If you tell all
Yes,
these
sir.
complications, patient will just not get the surgery done. Right? So counseling doesn't mean that you just tell about the complication. You have to tell these disease process and why the surgery is needed. That is also important.
Yes,
You
sir.
can't manage cholestoma medically, right? So we
Yes,
need to emphasize the need for surgery also. And what is the aim of surgery? फिर complication आएंगी बाद में.
Yes, sir.
ठीक है?
Yes, sir.
Right. Okay. So what approach will you take for this patient? What
Sir,
surgery you want to take?
Sir, modified radical mastoidectomy.
Okay, so what do you understand by modified radical mastectomy?
Sir, modified radical mastoidectomy, it's an operation to eradicate the disease of middle ear and mastoid, in which mastoid, middle ear, antrum, attic are exteriorized into the external canal by removing the posterior meatal wall. And all the remnants of the tympanic membrane, chorda tympani, ossicles, and the linings are removed. And
You will remove all the ossicles, even the
no,
stapes.
sir, we will no, sir, no, sir. We will, the remnants and the functional ossicles are preserved, sir.
Right. So you try to preserve whatever hearing mechanism is there, you try to preserve it.
Yes,
Right.
sir.
So basically, modified radical mastectomy is a canal wall down procedure.
Yes, sir.
Right. Okay. So what approach you would like to take? Inside out approach or outside in approach?
Sir, since this
before
is the
that,
no.
Ravi,
Yes, sir.
before
Yes,
that,
sir. Yes,
Ravi,
sir. Yes, sir.
can she count some other canal wall down procedures? And what are the procedures which are called canal wall up procedures
Okay.
in
Yes.
mastoid surgery?
Right. So Dr. Pasi has a very pertinent and important question.
Sir, in cortical mastoidectomy or simple mastoidectomy is canal wall up.
Yes. First, you tell us what are the other procedures which are in the category of canal wall down other than modified radical mastectomy?
Radical mastoidectomy.
Okay, radical mastectomy. Can you tell us some absolute indication of radical mastectomy today? In what circumstances will you like to do a radical mastectomy these days?
Sir, when
You
we
must
have
have not seen a radical mastectomy so far.
no, sir.
So that means it is not done frequently.
Yes,
Yes.
sir.
So when will you need to do it?
Sir, when there is when we have to approach or when there is a case of glomus tumor and we have to remove it,
No.
or if there is any, we have to reach the petrous apex, or when there is carcinoma of middle ear, and sir, when all the cholesteatoma cannot be safely removed, when the cholesteatoma is invading the eustachian tube or perilabyrinthine area.
No, you can remove cholesteatoma from these areas these days. You can remove all of it, even petrous apex.
Sir, in glomus tumor?
Not in glomus tumor, cholesteatoma I am talking about. Removal of the cholesteatoma can be done in the eustachian tube, in the perilabyrinthine area, as well as petrous. When we were students like you, then it was not possible. We used to be taught like this.
Sir, can I comment, sir?
Yes, Ravi.
So, I mean, nowadays we have endoscopes available, so you can actually access areas which are hidden now,
Yes,
right? So
that's-
earlier, cholestoma extending into a deep sinus tympani pocket or in station tube might be unresectable, but it is now resectable. So
yeah,
again,
that's
but
what I mean to say. Yeah.
yes, but again, sir, even after using endoscopes, there can be some situation where you are not able to resect, and these are called as unresectable cholestestomas. So in patients with unresectable cholestestomas, again, there is an indication of radical mastectomy, though it is very rare. I mean,
We hardly see such cases
yes, sir.
these days. We have
Yes, sir.
limited cholesteatomas now.
Yes,
Anyway,
yes.
what is the okay?
Second, and
He has told the glomus and the malignancy. That's right. These are the indications of radical mastectomy.
sir, again,
Right.
there are two more indications. One is cochlear promontory fistula and perilabyrinthine osteitis. So these are the two indications. In fact, there were three indications which were mentioned in Schambug. And one of the indication is unresectable cholestoma. Second is promontory cochlear fistula, and a third is perilabyrinthine osteitis. And I would not say that I would say that the malignancy of the middle ear, if there's a malignancy of the middle ear, it is not radical mastectomy which is done. It is basically subtotal petrosectomy. So even if there is a
Yeah.
malignancy, that is the correct surgery which should be done for a malignancy of the ear.
That's right.
There is an old indication when there is no residual hearing and there is an extensive cholesterol.
Right.
Yes. Dead ear.
Right.
Dead ear due to cholesteatoma.
Actually, sir, even like, nowadays, even if the patient's ear is dead, we prefer to do a modified radical mastectomy. Even if the ear is dead.
What I said is dead ear with extensive cholesterol.
Okay, right. So extensive cholestoma, which is unresectable and patient has dead ear. Agreed, sir. Yes, sir. So can we go ahead, sir?
What are the other canal wall down procedures?
Sir, modified radical mastectomy.
That you have said.
Sir, Bondi procedures.
Now the question is, what is Bondi's procedure? So if you don't know, don't answer. That is you should not lead the examiner.
So rest, I don't know, sir.
Acha, okay, so anybody who can tell us Bondi's procedure? So Bondi's procedure is also a type of canal wall down procedure where you remove the posterior canal wall and exteriorize the mastoid without touching the middle ear ossicles and the tympanic membrane. So this was a surgery which was done earlier, but nowadays we don't do Bondi's. Bondi's is basically exteriorizing the mastoid by removing the posterior canal wall and exteriorizing the cholestoma. Okay. So this is again an obsolete procedure we don't do nowadays.
We call it as aticoenterostomy.
Yes, sir.
Okay, modified radical mastectomy you will do in this case.
Yes,
And
sir.
how will you avoid the mastoid cavity problem? Can you do something on the table before you come out of the OT?
Yes, sir.
Hmm.
Sir, complete removal of the disease.
Yeah, that is all right. But how are you going to avoid the mastoid cavity problems in a modified radical mastectomy patient?
So saucerization of the whole cavity.
No. You are telling us how to do a
Intraoperative.
medical modified radical mastectomy perfectly. We are not asking you that.
Yes,
We're
sir.
asking how will you avoid the mastoid cavity problem? Mastoid cavity is anyway there in MRM.
Sir, by cavity obliteration.
One is cavity obliteration. Do you know the long time results of cavity obliteration operations, whatever way you do it? Not very encouraging in the long run.
And sir,
What is the best remedy?
the reconstruction of the posterior wall.
Posterior canal wall reconstruction. Yes, but how can you do it?
The palva flap.
Valve flap. Okay.
That is for cavity obliteration, not for
This
reconstruction.
is not for reconstruction. Reconstruction means you will have to erect a wall of the posterior canal.
Bone pate.
Bone pate. Bone pate or what is that bone? Bone pate, okay. This is
Or the bone dust also, sir. Bone dust.
yeah, theoretically
Bone wax, bone dust, bone pate.
not bone wax. Not what is bone wax? Have you seen bone wax?
Yes, sir.
So what is it used for? Bone wax is used for what?
To cover the dural effect. It is used to cover the dural defects.
No,
Okay.
not dural defects.
We
It is used to
use it for control bleeders.
bleeders.
Bone
Yes.
bleeders. Bone bleeders.
Bone bleeders. Yes, sir.
It is a foreign material. It contains beeswax and Vaseline. Okay. So
Yes,
it is a
sir.
foreign material. If you just put it in the mastoid, it will just get extruded. It is going to extrude. I mean, it is not going to stay there. It's a foreign material. We should not be using bone wax for mastoid obliteration.
What is hydroxylapatite?
So calcium hydroxyapatite is calcium.
What are the different forms in which it is available and what form you can use in the posterior canal wall reconstruction? It is available in the form of powder, it is available in the form of granules, and it is also available in the form of blocks.
Blocks, yes, sir.
Blocks can be used for reconstruction of the posterior canal wall. What is the best material, autologous material, which can be used? Dr. Ravi doesn't seem to be happy with the use of synthetic materials.
Yes, sir. So you can use this
Graph.
conchal cartilage.
Conchal cartilage.
Yes.
Conchal cartilage has a curvature also and can be used to do a soft wall reconstruction of the mastoid, right? Posterior canal wall reconstruction using conchal cartilage. So they're basically, sir has asked you about the reconstruction of the canal wall, and there are two techniques basically. One is reconstruction of the canal wall will avoid cavity problems, and second is you can obliterate the cavity by various materials like cartilage or bone patty or muscle flaps, musculoperiosteal flaps, like you told about the Palwa flap, and then there are Singapore flap, and there are a lot of flaps which have been described, right?
Yes, sir.
You can use it for obliteration, and obliteration will reduce the size of cavity, and once the size reduces, the cavity problems also reduces, right? So
But the important thing, Dr. Ravi, is before you do these procedure, you must be sure that you have removed all the disease, all
right,
the
sir, right.
cholesterol you have removed. You should be
Yes,
very
sir.
sure of your removal of disease.
Very important point by Dr. Singhal, sir. You
Yes,
must
sir.
ensure that you have removed, because you can't bury epithelium or cholestoma with these flaps. You should be 100% sure that you have removed every bit of disease.
So, Monica, what all you will do to ensure that you have not left any disease behind? What all what gadgets will you use to ensure that?
सर ने बड़ा important hint दिया है आपको ना. When you are appearing in exam, you have to catch the hints which examiner give you.
Sir, with the help of endoscope, we can look
Yes,
for
yes.
sinus
Very good.
tympani and facial recess.
Very good. Very good. Very good.
In a modified radical mastectomy, you will not have to inspect too many areas unless you are doing a canal wall up in a squamosal type of CSOM. But sinus tympani still needs to be seen, and sometimes sinodural angle area in a sclerotic mastoid. All right.
Yes.
Sir, Dr. Raman has given me
Sorry to
indication
interrupt,
that the time is up.
Yes.
Sorry for interrupting, sir. I think we are overshooting the time, but the topic of CSOM is, I think, endless. We can have endless discussion on this topic.
But
And
Raman, I have not heard the voice of Rubina.
yeah.
Let
Dr.
us
Rubina
hear
Arora.
something from her.
Yes, Dr. Dr. Rubina, please introduce yourself.
Yes, sir. Good evening, sir. Dr. Rubina here.
Sir, Dr. Rubina is a graduate from MAMC and she is postgraduate from Lady Harding, sir.
Oh, great. So, Rubina, your candidate has done fairly okay, but she needs to read more and she has to learn to express and
Yes, sir.
explain in a better way.
Yes, sir. We will use all the valuable input. It has been very informative for me as well, sir. So we'll be using all this knowledge, and we'll also perform better in the next one.
Yes. That is what this forum is for. We are just trying to stimulate residents and all other younger group of ENT surgeons to read more, to attend more workshops, etc. And there should be a full encouragement from your side to your junior residents in particular.
Yes, sir. I will do that.
हमारे जमाने में रुबीना you will recall कि HODs बहुत ज्यादा encourage नहीं करते